Hello, everybody, and welcome to our tips and tricks presentation tonight. It's great to have you here. The last couple of these were done by Dave Klein, one of the owners of PayDC. I'm the clinical director. I'm Dr. Evan Gwilliam, and I'll be hanging out with you a little bit tonight. I want you to know that this is intended to be very interactive. So insert comments and questions. They don't even have to be about this topic. Odds are that if you have a question about something, somebody else in your group does too. And so we want to make sure that we get everybody's questions answered and we address them. That's the point of this tips and tricks forum. So without further ado, what I plan to do with you this evening is talk to you about ICD-10. Some general concepts, but also specifically how to maximize and leverage how the software works around the diagnosis codes. And so here's what we're going to do. First, I guess there's me. Actually, that picture's a few years old. Time to get a new one. Just so you understand, I'm the clinical director for PayDC, which means I'm here to help our doctors get better records that matches their clinical needs and all that fun stuff. So let me know how I can help. I have all the certifications and qualifications to back me up, and they're here and you can see them. But let's get to the meat and the content. I don't plan to take your whole evening. I have a few things I want to share with you, some good tips, and then I just want to field your questions and see what's coming in. So I'm going to keep those open on another screen and watch and see if questions come in, and we may save them to the end, or I might answer them in the middle if it makes sense to do so. All right. So I want to begin by just reviewing a couple of ICD-10 guidelines, and then I want to show you how they pertain to how you set up your care plans and your daily notes in the system. In ICD-10, in the guidelines, section 1C19, paragraph B, it says the code for the most serious injury as determined by the provider and the focus of treatment is sequenced first. So these are the codes we use to tell the world what the problems are with this patient and why they need care. So diagnosis codes help establish the necessity for the care that we're going to provide. In section 4, paragraph G of the guidelines, it says list first the ICD-10-CM code for the diagnosis, condition, problem, or other reason for the encounter or visit shown to be chiefly responsible for the services provided. What all that means is that the first code that you should report is the one that's the main reason for the encounter. And the other guideline, it says the most serious problem should be listed first. And that guideline does pertain specifically to injury or accident codes, such as those that start with the letters S or T. However, the concept is that whatever the patient has that's the worst, that is what we should, that's what we should report first. And we should convey that as quickly as we can. In other words, at the top of the list in case the ones at the bottom don't even get noticed. We want to make sure that they're counted. Now, Medicare in the past has published their LCDs or local coverage determinations. The one for Novitas breaks the diagnosis codes into groups. And they say these types of codes are good for short-term care. These ones are moderate and these are long-term. And so it's useful to refer to that to say, oh, so a payer might expect sciatica to require more treatment than lumbalgia, for example. Lumbalgia is a short-term code, sciatica is a long-term code. So you can justify more treatment if you use codes that are part of these longer-term groups versus the shorter or moderate. Okay, so what I'd like to do then is take this information and roll it into kind of a recommendation for you, and that is that you should consider putting your codes in this order. Okay. Now, Medicare tells us that we have to put the signal dysfunction or M990 diagnosis code first. That's fine. Follow your payer's guidelines. If other payers tell you, have given you guidance on specific diagnosis codes they want it a certain way, follow them. And then after you've satisfied them, consider this hierarchy. Okay. This hierarchy is made up by me. So it's just an idea. And the idea is the most serious things are at the top and the least serious things are at the bottom, taking into account ICD-10 guidelines to make sure they've been accounted for and addressed. So I believe that the most serious types of conditions that chiropractors treat are the nerve-related disorders, such as radiculopathy or perhaps sciatica. The second most serious thing that we treat, and therefore the second most important thing that gets to the top of your list of ICD-10 codes, is acute injuries such as sprains and strains, followed closely by structural diagnoses, which we use something like a degenerative disc disease. It's not acute, but more chronic. And then if you use functional diagnoses like difficulty walking, those are not as important, but they can certainly get on the list. Now, the last three, I think, are the least important and the least valuable in establishing medical necessity for your care. You've got symptom codes. So that's things like neck pain and low back pain. My problem with those codes is that they don't describe the patient's actual condition. They're just a symptom of the condition. So my advice to you, if you're tempted to use a code like neck pain or back pain, is to say, due to, and then finish the sentence. Say, neck pain due to what? And if you can come up with what's causing the neck pain, you'll probably pick something that's higher up on this list, and it's a better diagnosis, it's stronger. And you should identify that and move it up. If all you've got, the best information you have is, now the neck hurts, I don't know why, I don't know what's causing it, I just know it hurts, and all you got is neck pain, you can use that diagnosis. But it's weak, it's way down the list, it's not nearly as strong as radiculopathy or a sprain or something. Now, the ICD-10 guidelines also tell us that we can report things like comorbidities. We're supposed to report anything that affects patient care management or treatment at the time of the encounter. So we could list codes that aren't even something we treat, like comorbidities such as diabetes or pregnancy. You can, the guidelines allow you to. You don't have to, and in fact, if you're nervous about it and you think the payer is going to reject it, if you use a code like diabetes, then don't. My advice would be, if you list these as diagnosis codes, you make sure they don't link to anything. So they could be on the claim form to tell the story that the patient has diabetes, which complicates the case. But I wouldn't link it to the adjustment. I'm not adjusting them because of diabetes. I just want the payer to know they have a comorbidity without having to send in my records. I just list it on the claim form at the end. That's one of the last codes. Okay. So that's how I would handle those conditions that you want to include in the coding beyond just your documentation, but you don't necessarily want the payers to think that you're treating diabetes with an adjustment. The last one on this list is external cause codes, and in the guidelines for ICD-10, it says external cause codes should be listed last. So that's why there's the bottom of the list here. These are codes for things like a place or an activity for an acute injury. So there's codes for things like walking down the hallway in a hospital, on a swing set at a playground, in a pool at a public facility, stuff like that. And they don't actually describe the condition either. They're just external causes. They explain the cause of an acute injury. So if you choose to use these codes, they would be the last ones on your list. They start with V, W, X, and Y. If you're not familiar with them and you never use V, W, X, or Y codes, you're probably fine. They're optional. We're not required to report them, but if we do, they should be last. Okay, so that's my hierarchy. So if you're supposed to put them in this order, what can you do in PayDC to maximize this? Well, let me move my screen here. Let's make sure you're seeing what I think you're seeing. Yeah, so I'm just here in the software, and I'm in a patient by the name of Peter Parker. You might have heard of him. If I go into his care plan to make an edit to it, I can go to the ICD-10 code screen here. I'm going to edit this care plan. And if he was truly a Medicare patient, for example, I could set up my diagnosis code hierarchy based upon what I know of the Medicare rules. So I'm just going to flip a couple screens here till I get to the ICD-10 codes for the care plan for Peter. And you can see here, these are the diagnosis codes that are going to be displayed on the claim form in this order. This is a Medicare care plan, so I've saved it with these diagnosis codes. M9901 is first, followed by radiculopathy, followed by M9902, which is thoracic, followed by a thoracic pain diagnosis, followed by a couple more M990s and another symptom. So what I've done is I followed Medicare's guidance to put M990s first and third and so on. But after that, I've listed the most serious things. I think radiculopathy is way more serious than pain in thoracic and low back. So that's why it's at the top of the list after I've satisfied the payer by including those segmental dysfunction codes here. Okay, so that's what I'm trying to leverage here is saving these in this template in a way that I can come back and reuse this care plan, and my diagnoses are more or less set up. If I have another patient later that has something similar, I can use this care plan template and then go, oh, but you know what, they didn't have the thoracic stuff at all. This patient doesn't. So I could get in here and find those codes. I could either scroll down or search for them alphabetically, or I could type in a few letters of those codes and get in and say, you know what, since this patient is different, we're going to get rid of M54.6, and we'll get rid of M902 as well. And so I can either, like I said, I can scroll down to the 90s, or I could have typed it in or searched for it alphabetically. So let's get rid of the thoracic and just keep these other ones. So now it's cleaned up a little bit, you know. In fact, let's put this one down at the bottom. So, I mean, you can save the template in the sequence you want and then change it on the fly for that specific patient, okay? And it's important that you leverage that. So that's the diagnosis hierarchy I wanted to share with you. Let me pull my presentation back up. There we go. So that's the hierarchy that I would suggest you follow. Part of the reason that you want to do that is because rumor has it that sometimes the computers that process the claims only consider the first couple of diagnoses anyway. They don't really even look at the further ones. So make sure the good ones are at the top and your less powerful diagnoses are at the bottom, okay? Now, another little bit more on ICD-10. This is just a table I threw together that summarizes all the changes since 2016. For those of you who don't recall, 2015 was the year that we began to use ICD-10, and then they added and changed the codes every October 1st. Good news for you guys is those are automatically put into PayDC. So when you log in, you'll have the changes updated. And then you have to decide if you want to add those new codes or revised codes to your favorites. And if there are some that pertain to chiros, we'll make sure to alert you through this forum and other means to make sure you know which ones you should use. But you'll need to find them and then add them to your favorites, which I can show you if one of you wants me to. You can ask that question. I'll make sure if somebody wants me to show you how to narrow down your ICD-10 favorites list, I will do that with you. But I want to show you some changes that are proposed. Well, this one wasn't proposed. They've never done this before, as far as I know. They added a new code April 1st. It's our friend COVID. COVID-19 now has its own diagnosis code. It's brand new, and they usually wait till October, but for some reason this year, they thought it was important enough to throw it in April. So now there's a diagnosis code for that. You're not going to need that, but I just thought you might find that interesting. Good to know. Now there's some other codes that have been proposed. I want to share these with you. There's 21 chapters currently in ICD-10, and I'm talking about a 22nd chapter. And so here's some examples of the codes here. These are codes related to infectious diseases caused by zombies. So you see there's a section of codes about allergic reaction to zombie saliva, dogs, and hair. There's certain zombification of body parts. We have a list of all the different body parts that can become zombified, and so you can code those separately. And there's total zombification. My favorite, though, is ZA1.2, which is nausea caused by zombies. And you see we have nausea caused by zombie stench, appearance, but this one's my favorite, nausea caused by neighbors massacred by zombies. And so these codes, in case you didn't look to the bottom of the screen, were added as a joke several years ago, April Fool's Day, but I couldn't resist. So there really is no chapter 22 zombie codes. Okay, there actually are proposing a chapter 22 though, with code start with letter U for temporary things like COVID. So anyway, that was just a little lighthearted. See if you guys are paying attention. All right. So I want to talk about one other group of codes specifically for a few minutes and some issues around them. Then again, I'll either wrap it up or we can do some Q&A if you guys want to. Actually, before I show you this slide, I want to point out that I added a handout to, if you look in the toolbar, there's a handout there for you, and it is this simple Word document. What I did was I copied and pasted a good ICD-10 list for you. Here, let's make this bigger so everyone can see. There's not really any preamble. It's just a list of about 150 diagnosis codes that I think chiropractors should consider using in their system. So we've got the disc disorder codes and disc displacement, and there's about 4 pages of codes here. All the shoulder codes I think that chiropractors might use. So there's 4 pages of codes. So the question is, what good does this do you guys? Well, if you download that handout that's attached here, or if you're watching this recording later, contact support and we can just send it over. This is really just a simple list of codes. My advice to you is to compare these to the codes you already have selected as your favorites. So there's 4 pages long, okay? It's just a bunch of ICD-10 codes. And my advice to you is to take a moment to go in here, go into the advanced settings, okay? Go down to the functional preferences, and under the care plan heading in functional preferences, you can access the ICD-10 code list, okay? So as a quick refresher to you, if you display full ICD-10 codes, it's the current code list as of October, with all 72,000 plus codes in it. If you don't, then it will just show the ones you chose to include in your favorites. So I want you to take that list, that little handout list, and compare it to the ones you already have in your favorites and see if there's some that you might have overlooked and want to add, or you decide they're not relevant to you. Maybe you never would diagnose foot drop. That's fine, just unselect it and hit save, you know. But my suggestion is to come up with, you know, the 150 codes you're going to need and use on a most consistent basis. And the easiest way to add new codes in here is to just type in the 3 or 4 digits of the code itself and hit search. That's my favorite, but you can also type in keywords. It's just really hard to find a good keyword. If you type in shoulder, it's going to return, you know, if I did the whole ICD-10 list, it would return hundreds, if not thousands of codes with the word shoulder in it. So it's better to look at the list I've given to you and type in the code itself, then add it in and hit save, and you should be good to go. Okay, so that's just a quick review of how to add and enhance this. The ones that are checked off here are the ones that are going to show up as options when you're using the care plan wizard or here in the SOAP notes. If I'm in a SOAP note here for Peter Parker, just so you know, it looks very similar to the interface in the care plan wizard, but you can go to add diagnoses down here under the assessment, and you can sort this list alphabetically or sort it numerically or type in a keyword. And this is only going to show my favorites now, not like in the settings, I can do the whole list, but now I have 20 favorite shoulder diagnoses. And here they are, and I could throw it on the case. And now this patient has the shoulder diagnosis right here. You can also change the hierarchy here. So if you set up your care plan wizard and you're good to go, then you're good to go. But see, this patient, maybe he's Medicare, and I shouldn't have lumbago sciatica first. I should have segmental dysfunction first. So you can reorder the codes right here. All right, and you can change their sequence and you know, put them in their place so that they better align with click and drag. Or I can say, really, they don't have bicipital tendonitis. Let's get rid of it. I can eliminate it, and so on. So you can change your diagnosis hierarchy right here. I really strongly encourage you to get down here into the procedures, and also take a moment, usually on the first visit, to link the diagnoses to the specific services that you're interested in. So I've already done it with this case. You see that the 9941 and 97014 pertains to all diagnoses, but for the 97110, which is therapeutic exercise, I said that this was really only for these problems in the back and not for these other ones in different parts of the body. And that helps establish that this service has its own purpose and goals and so on. It's necessary for some codes where you have to put them in different body regions, like 97140 or 9943. Those need to be separate body regions. So you should link them to different diagnoses to help prove that and show that linkage, okay? So that's how you can kind of leverage that inside of PayDC. Let me go back over here. I want to just go through the guidelines with you a little bit on 7 characters for a minute. And then I want to talk about sprain and strain codes. So that's the other things I wanted to address with you tonight. As before, I strongly encourage you to throw in questions if you got them. Toss them into the toolbar, and I'll watch for those and we'll answer them at the end. So I just looked up the code here for strain of muscle, fascia, and tendon at the neck level. It's S16.1 XX, and then you get to choose a 7th character. It's either going to be A or D or S, and you have to know what these mean. I literally was working with an audit client just a few days ago, and they thought that you should put the A down for the first visit and the D down for every other visit because it's subsequent encounter, right? That sounds right. Well, I need to go over some guidelines with you guys to make sure you understand what you should be doing here. If you look up the 7 character guidelines in ICD-10, it says that A is for initial encounter, D is for subsequent encounter, and S is for sequela. That's fine. Initially, that makes it appear like usually A, the first visit, right? But it does say, while the patient is receiving active treatment, including continuing treatment by the same or different physician. So it's not just for the first encounter. It's a little bit misleading for them to name it this way. I wish they had said this is for the initial treatment encounters, because that's what it's for. It's for the encounters while you're treating the patient to get the problem better. So I think this phrase active treatment is important. D is for subsequent encounters, and this is routine care later during the healing and recovery phase, like aftercare and follow-up. So here's an example. Let's say little Johnny broke his arm, okay, and he goes to the physician, and the physician sets the bone, puts a cast on him, x-rays it and all that, and sends him home. That would clearly be the A for initial encounter for that arm fracture. Let's say Johnny comes back a week later, and the doctor looks at it and x-rays it and says, oh, looks good. That's a follow-up visit. That's aftercare, because the active treatment's already done. There's no more active treatment for the fracture. Now it's just recovery, healing phase, and the doctor would assign the D to that fracture code. But that doesn't really work for the soft tissue diagnoses like strain, because a strain you don't just treat it once and then be done and just do follow-up. You treat it over and over again. You're doing active treatment for multiple encounters that are considered continuing treatment. So my advice to you is to use the A for all encounters where you're providing active treatment, and only switch to the D when you feel like your patient's condition is more or less done and you're just checking to look at it. Aftercare, okay? Sequela is a little different. This is something that's a result of something else. So the example they give here is scar formation after a burn. So you could use sequela to report the burn, and then scar formation to report what you're treating. But we're saying the scar came from the burn. I'll explain that one more in just a second. First, I want to show you a little bit more in the guidelines that explains how to choose whether it's an A or a D. In bold here, it says, while the patient may be seen by a new or different provider over the course of treatment for an injury, assignment of 7 characters based on whether or not the patient is undergoing active treatment and not whether they're seeing someone for the first time. So as a result of that, my advice to you is to document active treatment and use that phrase right there in your notes. Create a macro I'll show you how to do it, in fact. I would advise you to create a macro that discusses active treatment. In fact, let me just escape. I'll come back to this in just a second. So you could get in here and put under the plan or the assessment section, maybe say this patient, like this, is currently undergoing active treatment for the, you could say for the injuries from the car accident, or you could say for the sprain strain. I mean, this guy doesn't have one of those. I could add that diagnosis. You could say for the strain of the neck, you know, of course, or you could say for the injuries resulting from this accident. I think either one would be adequate. And then you could take this thing, if that's something you want to use all the time, then we could just make this a macro here. So let's do that. Let's make this into a macro. I could also go like this and make sure it saves on every visit, so it just states that every time. And I'm going to go into the macros and create one now for this. Oh, there's a punctuation issue. But look, I go into the macros, here's my macro dialog box, and I want to add a new one. So here's my macros, and I go, yeah, let's add a new one here. And let's call it ATX. That's activator. I don't want to confuse with activator. Active treatment. Well, I don't know, active, ACT. If I don't have that already, that's good. And I can put in that whole sentence. Okay. And this is how you use the macros, right? And then we save this. So there's my macro. The next time I want to use it on another case, I don't have to open up the dialog box. I can open up the dialog box and check it off and add it like this. You see now I just added it in there again. Or I could have just typed in /ACT and the whole thing drops in. And so that's my advice to you when you're doing, in fact, I guess that would make more sense after the diagnosis codes. So we could possibly print the assessment. Either way, I'm not sure that I have a preference where that might belong. But, you know, I would also need to add a, let's just throw in for strain of the neck. Let's do neck and see what we got. There it is. Strain of muscle fascia and tendon at the neck level. Okay. So now I have a good reason to use that A as my 7th character, because I have the words active treatment listed right in my records here, and that is exactly what it says in the guidelines for ICD-10. So no one can question whether or not the A is appropriate. When you finish care for this patient, you have no more active treatment for them. Release them from care. You could add the D, I guess, at that encounter, but I think that you're done treating them when they are no longer under active treatment, you know? And so that's how I would use that, okay? So I'm going to go back in here and talk about the last bit of this, which is sequela. Sequela is the S for these 7 characters. So here's the guidelines from ICD-10 that talks about what sequela is. In ICD-9, it was called late effects. And it's basically the residual effect after the acute phase of an illness or injury is terminated. So we talked earlier about a burn leading to a scar. So the residual effect would be the scar. The acute phase was the burn that had to be treated. Or the example here, another one is paralysis after cerebral infarction. Someone has a stroke, that's the acute illness. The residual effect of the paralysis. So you can have a patient you treat for paralysis, and you could put in a code for the cerebral infarction and it with an S to say, look, cerebral infarction is not being treated, it's done, it's gone. But it caused the paralysis, so we're treating that. So the guidelines tell us to code first the condition being treated, and second, the illness or injury that led to it. Never code for the acute phase of an illness or injury with a sequela. So the acute thing is done and resolved and gone. And so you don't have to code for sequela. I like it because it tells a story more thoroughly. But you know, the risk, of course, is always that a payer doesn't understand these rules and they go, wait, you're treating someone with a stroke? Like, no, I'm treating paralysis. I just put that code in there with a S for sequela to explain to you that the stroke is the cause. So you don't have to ask for my records because it's right there in the codes. The codes will tell the whole story. And that's the purpose of reporting sequela if you choose to do so. Okay? So those are the 7 characters, A, D, and S. My advice to you is to use the A all the time, and then when you're done with care, release them and don't use the others most of the time. But now you know when you could use the others, okay? There's one more thing I wanted to go through with you tonight. It'll take just a few more minutes. I want to talk a little bit more about sprains and strains and just kind of dial it in here a little for you, and then go in and make sure we've got it documented properly on Peter Parker. So here we have some sprain and strain codes I put into a table. You know, we got the cervical sprain, the cervical strain. We have the thoracic sprain, the thoracic strain, the lumbar sprain, and the lumbar and lower back strain, and then the pelvis down here. So what do you need to know about these codes? Well, keep in mind that although most patients who have a sprain also have a strain, they must be coded separately. You can't just code one and assume everybody knows. And if I were you, if you're going to do, like soft tissue work, strain is a great one to code for because it helps justify soft tissue because soft tissue damage. The sprain, however, is, joint damage. And so if you're doing things to help that joint out, then that would be a great diagnosis point to those services. As I stated here, the 7-character A is the most likely choice for these codes as long as the patient is undergoing active treatment. So you'll put active treatment right there in your records. Oops. If you want to do sprains and strains for the extremities, they follow a similar pattern where they all start with the letter S. The second character is going to be the location, like 6 for the wrist or 9 for the ankle, if you want to do sprains or strains there. And the third character is going to be a 3 for sprains, 6 or 9 for strains. You can just look them up. There's too many codes to list here. Keep in mind also that a lot of conditions like strains of muscles include pain. So it would be incorrect to code for cervicalgia along with a strain of muscles of the neck because strain of muscles of the neck includes cervicalgia. Since it's routinely associated with it, I don't know anybody who could strain their neck and not have pain, so there's no reason to also code for the pain, okay? And now, if I were to look at your objective findings in your note and you needed to support a diagnosis of a sprain, I would expect to see palpation, pain with passive assisted motion, maybe flexion extension or digital motion x-rays, maybe an MRI. If you diagnose them with a strain, I would like to see palpation, pain during muscle contraction, and maybe an MRI. The difference here is that strains are ligaments which can't contract, so it would be passive motion, and with strains it would be active muscle contraction because it affects the contractile tissues that have been damaged. If you don't document any of these things and you diagnose your patient with sprain or strain, I think that you don't have enough justification to do it. So we should make sure that your records show these kinds of details, okay, for either of these types of conditions. And if you use these diagnoses, these are great, in my opinion, these are great CPT codes to attach to these diagnoses. 97140, 124, and 110 are great active treatments to do to help correct for sprains and strains. These 970s are better for the initial stages of care because sprains and strains often have a lot of pain and swelling and that sort of thing. And so you can use things like ultrasound and hot and cold and electrical stim to help treat that pain and get it down so that you can push the patient into more active treatments here with therapeutic exercise and that sort of thing, okay? So I think that these codes could be great if they were linked to the sprains and strains in the ICD-10. If you want to do, therapeutic exercise and you link it to cervicalgia, well, I'd be a little bit like, why? What does exercise have to do with pain management? I mean, if you were treating a condition where they had shortened muscles, well, yeah, I get the therapeutic exercise, and that's causing the pain, okay. But if all you tell me is they have pain in their neck and you're doing exercises, it's a little bit like you're leaving out, what's the condition you're treating? Where's the condition? Just tell me it's for pain, okay? So let me show you kind of how we could go into Peter Parker here. And I've added this strain diagnosis code. We'll make it first now. So now it's strain. In order to support the diagnosis of strain, I would hope that your subjective includes something such as history of a trauma, an auto accident. And let's just say, I could put in here, patient fell out of a tree yesterday. His web shooter jammed. This is Peter Parker, right? So if his web shooter jammed, he fell out of a tree. So now I have evidence of trauma. That's good for documenting or diagnosing a strain. The typical pain that you would get reported with a strain might be pain at the back of the neck, maybe headache pain. Possible some patients with those kind of neck issues might have vertigo or difficulty sleeping. So I could additionally add those details here if I wanted to. In the objective findings to support the diagnosis of a strain, I would expect to see, or a sprain, well, I would expect to see discussion of range of motion and whether or not there's pain with it. So you can get in here and document the ranges of motion and then put in the free text here that there's, pain at C7 and, there's reduced and there's some guarding and pain and maybe there's also reductions here and this one has pain at C5 or something. Those kinds of little details that take you a moment to add will help support that diagnosis very well, okay? So now I have a few findings that support, a sprain or a strain. You could also show that you test the deep tendon reflexes to make sure you're kind of ruling out other potential neck issues like disc injuries. You could do some orthopedic tests like Sperling's Looking for radiculopathy. Got lots of cervical tests in here, and be Sperlings and say it was negative on both sides, and leave that alone. Those are the kinds of things I would expect to see documented. Tenderness in the neck region, of course, maybe some edema. So I could get up in here and put in where that tenderness is on both sides. So we add those tenderness findings, okay? And we can leave the rest for this patient. I could have started a new one, I guess. You know, edema would be common if it's an acute injury. So I could throw in the edema. Maybe it's in the joints and not the muscles. So we specify the joints here. We go, yeah, it's down here at C6-7, you know? So you can put in that edema on the left. And so that is, you know, those are all great ways to support the diagnosis of sprain or strain, to have that evidence in the history and then in the orthopedic findings, exam findings. And now that code is supported. And then down here, I can also now link it to that, which would make sense. It makes sense to do therapeutic exercise for this type of injury. Although I might uncheck these for the therapeutic exercise because it really doesn't tie to the segmental dysfunction. And I'm not doing it on the low back. So maybe it does tie to these, and I keep those diagnoses pointed to this one, okay? So that's how you can kind of bring it all together to create notes, you know, and if we look at this note, I got a bunch of other stuff in here. I should have cleaned it up. So if we look at this note, we can see if I got audited, an auditor could quickly look through this. If they just want to audit the issue of the strain, they could take a look at the note itself, they could print it off, you know, and send it over in a fax or whatever to an attorney or a peer reviewer or a claims adjuster. And once you do, you know, they should be able to find the answers quite quickly as to why or how, you know, it went behind, there it is, that is supported. So, you know, I have subjective findings that sounds like typical for a sprain or strain. I have objective findings here, like we said, some, you know, I added this tenderness and this edema. So those are good things to support that. Orthopedic tests, I threw in those couple of orthopedic tests. Oops, here's Sperlings, but it was negative. But just showing I was looking for other things. And then under the assessment, I've added the appropriate diagnosis code. And in the plan, I have a service that is linked to it, and its justification makes sense based upon that type of an injury that's been reported. Okay, so that's how we bring it all together in that record. So that actually is everything I have planned to share with you tonight. Trying to keep this down to 30 minutes for you. So I wanted to show you kind of those ICD-10 principles and then translate them into how they work in the system. We're going to be doing another one of these next week, same time. Let us know what you'd like to see or hear. You're welcome to email me or Dave Klein. Here is my email address right here on your screen, evan.gwilliam@paydc.com. Dave's is dave@paydc.com, D-A-V-E. Or Mary, whatever, just let one of us know what you need to hear, what we can help you with. Submit your questions. We could just read questions and do answers the whole time. Do any of you have any questions you want to submit to me right now? I didn't see anything come in, which means I explained it really well. Any questions? This is your chance. You got me on the line. It can be unrelated to ICD-10 if you'd like. Okay, but that's just what I chose to discuss with you tonight. This recording will be posted shortly. And so we'll put it in the forum for you guys to rewatch, the other members to see. You know, watch for it, put your questions in there, contact us, let us know how we can help. We're here to make your life easier, to make it so your software does all the hard work and all you got to do is show up and take care of patients and then plug a few things in. So let us know how we can help, and stay healthy and stay out of trouble. Thanks so much for having me.